So Sophia's going to talk now about the patient-reported outcomes aspect of this. And hopefully we hear some questions.
Good morning. Should I do it? Are they driving back there, or should I? Okay, hands off. All right, good morning. So I'll be focusing today on cancer center research that's focused on integrating patient-reported symptom monitoring and management into clinical cancer care. And among my objectives, something that I really want to emphasize is that the projects that I'll be discussing, they're not standalone research studies, but rather they're integrated into much larger healthcare system quality improvement initiatives. So our goal is for these things to continue long after the studies are done. But I'll begin with some background. As many of you, most of you know, and we'll keep hearing about today, cancer survivors can experience significant symptoms and unmet needs. Physical, psychosocial, late and long-term effects can extend years post-treatment, and some have other chronic conditions that require ongoing symptom management, particularly our older cancer survivors. We know that adherence to medical guidelines is often less than optimal, for example, early discontinuation of endocrine therapy for breast cancer. And like we heard about this morning, many cancer survivors, when they finish treatment, are really motivated to make these positive lifestyle changes, but they often don't get enough guidance to be successful, no more so than the general US population. And some of our cancer survivors have practical needs and require assistance managing the various life disruptions that are secondary to cancer diagnosis and treatment. So why is it important to screen for symptoms in oncology? Well, research indicates that routine screening can identify symptoms that could otherwise go underreported by patients to their clinicians. And many of the common symptoms that we're dealing with, they're really best captured by patient reports. So I'll be talking a lot about anxiety, depression, pain, fatigue, and physical function. So these are things we don't have lab tests for or imaging. And another good reason to screen, as you'll hear later in the keynote address, is that leading organizations have recommended doing so. And research also indicates, though, that screening alone is just not enough. So patients with significant symptoms need to be connected to relevant care. And studies indicate that when there's timely intervention, patients, in fact, do have better outcomes. So increasingly, research is focusing on implementation and dissemination. So it's really now about getting quality programs into the hands of patients and clinicians. So the fact is, we have a wealth of empirically supported symptom management and supportive care interventions, as you've been hearing and will continue to hear today. And there are clinical practice guidelines for supportive care, as Dr. Flores and others have mentioned. The National Comprehensive Cancer Network has them for distress management, for fatigue, and for various survivorship concerns, among many others. What we really need more of are better ways of identifying which patients need help and when, because we know that patients often need assistance getting to supportive care in particular. And research indicates that physicians can substantially underestimate patients' symptoms, particularly the emotional and psychological ones, for all the reasons that we understand within healthcare settings, with that limited time in a medical appointment absolutely being the biggest culprit. Research also tells us that patients are more willing to discuss their emotional distress and other symptoms if the clinicians initiate the discussion. Ironically, clinicians often defer to the patient and attempt to be patient-centered to raise concerns, so that can be an unfortunate catch-22 situation. So a question that we routinely ask ourselves, that I'm sure is familiar to many of you, is how do we better assess and address patient concerns within the real existing healthcare system realities? So the truth is that routine screening can be a significant healthcare system effort. By just frame of reference, we see over 10,000 new patients here in the Cancer Center at the Central Region. So that's a lot of potential screening. But does it necessarily need to be a burden? So our follow-up question to ourselves was, well, how can we use health information technology to make universal symptom screening more feasible? Specifically, how can we automate parts of that process and make sure that it fits into existing clinical workflows? But first, we need to evaluate how is patient-reported symptom monitoring currently conducted in real healthcare settings. So at this point, and for a while, the majority of cancer clinics use short, static measures for this, usually single items. Those are the most popular. And pain and emotional distress are the symptoms that are most commonly assessed. Many of you in here are probably familiar with the NCCN stress thermometer. For those that aren't, you can see it summarized. It's clearly quick, easy to score, but research indicates that it does a better job of identifying anxiety reliably than it does depression. So the bottom line is that there's significant room to improve the status quo of how symptom assessments occur in real life settings. So I think many of you can relate to this comic about the experience of what it's like when you're trying to make improvements in a busy healthcare setting. So selling new solutions to overtaxed healthcare providers can be challenging for all parties involved. The Lurie Screening Initiative was our very first wide-scale, systematic, electronic health record integrated patient-reported symptom screening program. We implemented it in medical oncology here at the Cancer Center in our central region. And the big changes that it posed from the previous clinical practice was a full integration into Epic, our EHR, which offered automated administration as well as score reporting straight into Epic. At this point, we also moved to standardized state-of-the-science patient-reported measures, specifically the Patient-Reported Outcome Measurement Information System, or PROMIS. We chose PROMIS not just because it was developed in our department, but because it has a lot of favorable qualities. It offers measures that capture priority health-related quality of life domains in cancer. You can see the main ones highlighted here that I'll be talking about, and this gives you a sense of the health measures website where you can learn more about PROMIS. PROMIS measures are on a common metric such that we're able to compare scores across chronic conditions and the US general population. The measures we chose have been validated in cancer with severity thresholds for scores that are in the normal range, mild, moderate, and severe categories, so very useful for interpretation. It allows for computer administration and real-time scoring. PROMIS is based in item response theory, and a big plus of that is that there are computer adaptive tests that offer precise measurement of a much longer measure, but in brief, usually CATs or computer adaptive tests are 4 to 12 items only per domain. So the Lurie Screening Initiative, in that adult medical outpatients were invited to complete the assessment via MyChart, which is the patient-facing portal in Epic, 72 hours prior to their appointments with their medical oncologists. The assessment included PROMIS depression, anxiety, pain, fatigue, and physical function CATs, as well as checklist items of supportive care needs, specifically regarding social work and nutrition. The assessment results were immediately captured in Epic and were available to clinicians to copy into their progress notes if they were interested in doing that. Really importantly, any assessment with moderate to severe symptoms or any endorsed care needs prompted real-time clinician alerts that went into their Epic inboxes. So severe fatigue, pain, and physical function scores were routed to the oncologist, and moderate and severe, I should say, depression and anxiety scores, as well as any endorsed social work needs, were routed to the social work pool. Nutritional needs were routed to the dietitians. So here's a summary of some of the data in the Lurie Screening Initiative over 2 years. In that time, over 6,800 adult medical oncology outpatients received over 38,000 invitations to complete assessments via MyChart. So this was a heavy lift. And over 3,500 patients completed over 8,000 assessments. 55% of those responding completed over 2 assessments in that time frame. Overall, their fatigue, pain, depression, and anxiety scores were comparable to those of the general population. But as Dr. Flores mentioned earlier, Mean scores indicated that there were generally lower levels of physical function in patients compared to the general population, with severe scores in that domain prompting alerts in about 5% of assessments. It's important to note that more than half of the assessments at that point were triggering alerts based on supportive care needs, mainly nutritional. I have to emphasize that we've changed those items, so now patients don't just indicate that they have concerns, but they indicate if they want to be contacted by somebody. And since we did that, that percent has gone way down, which our dietitians and social workers are very happy about. And overall, in patients who were endorsing supportive care needs tended to have worse symptoms on the CATs, and patients who triggered any kind of clinical alert generally were younger, more recently diagnosed, had more comorbidities, and were racial ethnic minorities. So that's consistent, with what we see across the research literature. Patients with alerts generally also tended to have more healthcare service encounters in the next month, which is what you'd expect to see. So the Lurie screening initiative, which was between 2015 and 2017, was exclusively via MyChart. At that point, about a third of the patients in the cancer center were actively using it. So this was really happening at home prior to visits. At that point, the assessment was about 40 items and was taking about 8 minutes or so to complete on average. In September of 2017, we moved the assessment over to the NMPRO platform. And at that point, in addition to the MyChart capability, there was developed an Epic hyperlink such that non-MyChart users could get the assessment in clinic when they were roomed by medical assistants. That's what the clinics chose to be most feasible at that time. We reduced the assessment to about under 30 items so that it could take about 6-7 minutes to complete, which is really important because we do not want to slow down clinical workflow. And this was also around the time that us as researchers kind of took our hands off and let the clinical teams run this on their own. So this gives you a sense of patient score distributions. This is now in the NMPRO phase in the cancer center across the different domains, with green indicating scores that are within normal limits, yellow indicating mild symptoms, orange moderate, and red severe. And the purple stars are just there to highlight the score categories that would prompt clinical alerts. On the average number of assessments triggering clinical alerts is generally 6%. This is on the NMPRO platform for anxiety, 5% for depression, 3% for physical function, and only 1% for fatigue and pain. Now keep in mind that anxiety and depression trigger alerts when they're moderate or severe, and the others when they're severe. So here you see some of the implementation metrics for NMPRO and the Cancer Center, and keep in mind that this is with fairly passive implementation. So what happened when this was launched was that there was preliminary staff training and some patient flyers, but not a lot of continued engagement. And what we see is that since the switch over in 2017, the average percent completed of the assessments sent out is 20%. So there's been a drop, and we're trying to understand the reasons for that. Of those assessments completed, the average percent done in MyChart was 80%. So despite that hyperlink, most of the assessments are still happening at home. So I want to switch now and talk about our current projects, which are focused on improving symptom monitoring and management. Because our past work, I think, established really strong infrastructure, but as you saw from that last slide, there's clear room for improvement. We really need to better understand how do we improve adoption rates, and what is the feasibility, acceptability, and sustainability of this program across different clinics? How do we improve all those things? Luckily, we received 2 federally funded studies that were awarded last year to answer those questions. The first is a 3-year study that was funded by AHRQ. That's an R18 that we've titled CPRO Monitor. And the second is a 5-year NCI Cancer Moonshot Initiative study. That's a UM1 that we've titled New Impact. Here you see the key investigators listed, including some familiar faces from the symposium today. So the CPRO Monitor study, what it's focused on is expanding symptom monitoring beyond the central region here, also to the north and west regions of northwestern medicine. We're really trying to improve clinician usability and overall implementation. And we want to evaluate the implementation impact on not just patient, but also healthcare system outcomes. We have a sub-study with an analytic set of 4,000 patients, and another sub-study that will have 1,000 consented patients. So a really important part of what it's doing is we're trying to identify best practices for system-wide expansion. So we're looking at different ways to administer the assessment, and the first thing we're adding onto this is tablet administration in the waiting rooms, in addition to at home and with the MAs. And we're also trying a variety of different patient and clinician engagement strategies. The new impact study, that's focused on expanding from symptom screening to symptom management in cancer. So it includes an enhanced care intervention where patient symptoms inform materials that they can receive through a web-based tool to help them with their self-management. And this is the first time that patients are able to see their assessment results. So all those other rollouts we talked about, the patients don't get their results. This will be the first time they can do that. This one will also be in all 3 regions of Northwestern medicine, and this will also be the first one to go beyond English to Spanish language. I have to emphasize this is a very large study that will have about 12,000 patients. Here you can see the CPRO alert response workflow. Starting from the left, patients complete the assessment at home or in clinic, and the scores are immediately pushed into Epic. They're available to clinicians should they want to bring them up in an appointment to talk about with patients. And again, any severe scores are also triaged to the designated providers, who can also opt, and we expect them to do something before the appointment, reaching out via MyChart, phone call, etc. So I want to give you a sense of the patient experience of all this, and that is not a patient name. That is Christina Davis, who's our NM quality lead in charge of training and other implementation. So this is what they see when they're in MyChart and they get the invitation. Here you can see the link to the assessment in MyChart. And this is what a sample question looks like. This is from the pain interference CAT. Here you get a sense of what IMBAS messages for designated clinicians are when their patient has an alert. And for those of you familiar with Epic, I want to emphasize that you are able to get results from various menus because we know that everybody has their own style of navigating Epic, and we respect that. And the other thing I want to emphasize is that clinicians can view results for all the patients with completed assessments, not just those with alerts. So in the chart review menu of Epic, you can see what a questionnaire looks like in terms of an encounter view. And here you see that the clinician can actually see responses at an item level, and we've emphasized those that have a clinical alert. We tried to make this look like elevated lab values that clinicians are used to seeing. In the synopsis view of Epic, that's really the best place for clinicians to track patient-reported symptom change over time. You can see that there's a couple data points, including some with alerts in red, in table format, but there's also a way to see it graphically, which is probably the best way to look at change over time. So I want to humanize all this with a success story from one of our physician champions on the projects, who told us about a patient that she'd worked with for over 3 years of medical care. This patient's usually really positive, upbeat, but one day just seemed a little bit down, nothing really obvious. But this oncologist, being part of the initiative, looked to see if they had some patient assessment results, and in fact they did. And she saw there that his anxiety and depression were a little elevated. Not enough to trigger an alert, but it was a significant increase from kind of where he'd normally been. So this prompted the oncologist to ask him about his mood, and at that point he actually disclosed that he was having some depression and some worry that he wasn't able to travel, which is one of the things he enjoys most in life. At the end of that conversation, she refers him to supportive oncology services, where he ends up getting psychotherapy, medication, and happy to report that his symptoms resolve. He takes this kind of big lifetime trip that really contributes to his quality of life. So all of us love those kind of stories in our care. But an additional really important part of this story is that this oncologist, who is incredibly patient-centered in how she treats patients, she disclosed she probably wouldn't have followed up on that hunch in that appointment if it hadn't been and had the conversation without that symptom data in hand. So it really helped that process. We know we have to go further and move from symptom monitoring to management because clinicians are motivated to incorporate this into their work if there are clear and easy next steps about what they do with patients. Likewise, patients are more likely to complete these assessments, one, if their doctors tell them to or ask them to, and two, if they can see that it results in timely and improved care or resources for them. So in our new impact study, the enhanced care condition for that, even patients who don't trigger clinical alerts in those severe categories, say they're in the mild or moderate level of symptomatology, they'll have access to education, interventions, and resources via website. So this is a way to give them more resources without burdening clinicians with additional alerts for these symptom levels. So we're doing that through a symptom management web-based program that we're calling My NM Care Corner. On the left, you can see what the format looks like for the website, including some of the symptom categories it includes. And on the right, you see some sample content in the symptom library, in this case for fatigue. Here you can see the mobile format for patient use on their phones. And we have started some usability testing with patients and other stakeholders. So far, it's been generally favorable. So in terms of next steps, obviously we're in the thick of these current projects with results not coming out for 1 to 3 years. But we, at the same time, are incorporating these same patient-reported symptom assessments into other health information technology tools. So another study that's going on right now is developing an Epic dashboard that can be used by both patients and clinicians in medical appointments in order to improve their communication and shared decision-making. That one's funded by the Peterson Foundation, and we're currently doing it within advanced cancers, but there could be clear applications in survivorship where there are these big gaps in between appointments, and sometimes there's a lot to cover, and it's hard knowing what to start with. And of course, we have other mobile health interventions. I have a study right now that's a 3-month program with tailored health promotion interventions for post-treatment survivors to receive after those care plans that Dr. Kircher was talking about. So really the concrete next steps of what to do after a care plan. And you'll be hearing about studies that are culturally adapted for diverse patient populations from Dr. Yanez, who's speaking next. Thank you.